Our next speaker is our keynote speaker. Dr. Brandon Kitay comes to us from Emory University, where he is an assistant professor of psychiatry and behavioral science and director of behavioral health integration at Emory University School of Medicine. He'll be speaking about the collaborative care model, which is what we've come here today to really investigate and try to figure out how we're going to implement effectively in Oklahoma. He's going to be talking about that once we get it going. Are we ready to go, Brandon? Again, if you will, please welcome Brandon Kitay.
So first of all, I want to thank you for the invitation to come and talk about one of my favorite topics, which is collaborative care. And I also want to thank Zach and Jeff for stealing my Oklahoma thunder. You actually made a lot of what I'm about to talk about much easier, really the first half of my talk, setting up, why should we be doing things like integrated behavioral health, and why should we be considering collaborative care for multiple reasons. And so today, I'm going to give you a crash course in collaborative care, a primer on what is the collaborative care model and where does it sit amongst the landscape of integrated behavioral health solutions. Before we get started, first, some disclosures. I do have some corporate relationships. I do clinical trials work, nothing that's really going to impact what I'm going to be talking about today. And just to start with some learning objectives. So through participating hopefully in this morning's hour, and I do want to make sure we have time for really rich discussion and thoughts about how we could think about developing integrated care solutions for your home state. But my hope is that through participation in today's lecture, you'll be able to at least differentiate the collaborative care models specifically from other integrated behavioral health service models and solutions, and appreciate the robust evidence base supporting why we should implement things like collaborative care for our patients. You should also be able to appreciate what the barriers and facilitators are of implementing and adopting the collaborative care model. My understanding when I was invited to give this talk was that collaborative care adoption and uptake across the state by looking at, for example, market scan analysis of Medicare codes and Medicare utilization has been quite low in the state of Oklahoma. And quite frankly, this is the case nationally. And so really, getting collaborative care into the clinical setting is not a trivial task. It's a very complex model to implement. There are a lot of advantages, but it does require a lot of partnership and a lot of infrastructure in order to consider. And lastly, hopefully at the end of this morning, you'll be able to think through your health systems, your state care delivery mechanisms, and think through how you might critically appraise your readiness for change, your readiness to develop an integration solution, mostly from either the systems perspective or from the healthcare organization perspective. Because really there are so many different ways and different angles and different directions that you can begin from in order to implement an integrated care solution. But really it depends on things like who are your stakeholders, who are your champions, who is demanding that you integrate care, and who's going to help facilitate and support you with resources in order to do that. It can come from the clinical side, it can come from the state side, it can even come from the payer side, believe it or not. Payers at this point recognize that integrated care is a fantastic cost savings mechanism, and they may even be trying to incentivize you to do more collaborative care if you can facilitate that partnership. So before we even dive into what collaborative care is, I'm going to start with a little bit of a story. So I joined Emory University in 2020, and I was recruited to be the director of behavioral health integration. I don't know what that is or what my title really means, but I do know that the institution was really interested in integrating behavioral health care. And my first question to the leadership of the health system when they were looking to recruit me was, well, why do you want to integrate care? And the answers that I received were, we know we should do it. It just makes sense. Kind of like, no duh. All right. Primary care wants it. They couldn't tell me what it was, but they wanted some sort of integration. Okay. We had a consultant drop by. If anybody ever tells you that a consultant has stopped by, run in the other direction. And what was actually most worrying to me was, and we're about to hire 2 social workers. To do what? For what purpose? To what end? And what are two social workers going to do for the entire health system? So reluctantly, I took the position. Actually, very happily, I took the position because I saw an immense opportunity. But what I realized, my first step and my first job in this leadership role was to figure out what is the problem that integrated care is attempting to solve for. And this is something that all of you need to think through and have a good understanding of within your health system, within your organizations, before you begin approaching it with a solution like collaborative care. And so what was the problem that integrated care was attempting to solve for at Emory? There was some legwork done, and there was a survey of a handful of primary care physicians across multiple practices across the Emory Healthcare Network, and I'll describe what the Emory Healthcare Network is in a second. And I won't bore you with reading the individual action items or survey items here, but you can see that most of the PCPs strongly agreed that there was a big mental health problem within their primary care patient populations. And pardon my French, but it was damn near impossible to refer a patient to Emory adult outpatient services or other specialty mental health services within the health system. They couldn't figure out how to do it. Patients were not making connections to referrals. When they were referred outside of the practice setting, they never made it. And they would say things like, "Can't you just prescribe me medications?" All right. And so I did some searching. So similar to what Zach has done throughout the state and provided a really nice primer on what the current state of affairs are there. I looked at data from our health system and, well, what is primary care doing with respect to mental health treatment within the health system? What I discovered when I looked at over 350,000 primary care encounters from fiscal year FY 2020 was that 5% of all primary care encounters were billed for a primary F code diagnosis. And this is probably a gross underestimation of how much primary care they were doing. And when I stratified all of the top 10 diagnoses from all of those encounters that were linked to a billable event, not surprisingly, depression and anxiety were always amongst the top 10. They varied with respect to where they were in the rank, depending on what clinic we were looking at, things like payer mix, things like the socioeconomic status of the particular, where the clinic was located, but always a mental health diagnosis or two or three were amongst the top 10 diagnoses linked to a primary care encounter. And they were treating a lot of disorders. I mean, the majority of what they were treating were things like mood and anxiety disorders, the most common things that we typically see in primary care. But there was also a bevy of substance use disorders that were being managed, psychosis in some of the family medicine practices that were being addressed, ADHD and bipolar disorder that were being addressed. I pulled data sets looking at medication prescribing practices and saw all sorts of really wild and interesting things that primary care was doing. And so it's clear that within our health system, unlike what's going on nationally, primary care is shouldering the burden of mental health treatment within the United States. And so I also wanted to understand, well, how hard really is it to access a psychiatrist at Emory Healthcare? Maybe why is it so hard? The Emory Healthcare Network is massive. It's a large, heterogeneous health system comprised of over 80 primary care practices within what we call our physician group practice, let alone another 50 practices probably that have some other varying degree of business relationship with Emory Healthcare proper, but may not be, for example, a faculty practice or maybe sort of co-branded as an Emory Healthcare Network practice. And not only that, our adult outpatient services at the time when we looked at this data, which was FY 2021, only comprised 7.6 FTE of a full-time psychiatrist. Present state, we have 5 FTE of psychiatrists. So talk about turnover problems. We have turnover problems amongst physicians who are trying to provide adult outpatient services at Emory Healthcare. And on the bottom half, Emory is a destination treatment center. It's an academic medical center. We're a premier institution for specialty care in the South. And not surprisingly, in that fiscal year, we received over 20,000 phone requests from new patients who were seeking mental health services who had no established relationship at Emory Healthcare, primary care or otherwise. I don't know how we land on this number, but 7,700 patients amongst all of the internal referrals and phone calls eventually made it through some triage mechanism that year. And we only saw 2,500 new patients in that physical year alone for adult outpatient services. So what happens to all of these patients, right? That's the big question. What essentially happens is the model breaks down. This one-to-one referral does not work within most health systems, and especially at Emory Healthcare. So the teal circle represents our adult outpatient psychiatry program. You can consider this to be one caseload. And because we don't have a good mechanism for triaging patients, I don't think we have a really great understanding of what our mission statement is at the adult outpatient program at Emory yet. We get referred patients of all different degrees of severity. We are not incentivized to step up or step down care once our caseload volumes are full. We do not have adequate social work or care navigation support to help offload or off-ramp patients. And so we just have these ever-expanding caseload volumes for the psychiatrists. And once they're full, they're full. And our budgets do not allow us to hire more psychiatrists to meet the unmet need. And as Zach mentioned, we could mint twice as many psychiatrists through training programs, at the current state, and we still wouldn't have enough mental health professionals to fulfill all the unmet need that we require to service the patient population under this current model of care. And so what essentially happens is patients get backed up into primary care. Patients at all different degrees and severity of mental health illness are being treated and trying to be managed in the primary care setting, and nobody gets good care, or very few get good care. And as I mentioned before, primary care assumes the burden of behavioral health access. This echoes a lot of what Zach was mentioning earlier, just to remind all of the primary care physicians and clinicians in the audience of all the work that you're doing. 20 to 40% of primary care patients have some sort of a behavioral health care need. I mean, think about it, almost half of your patients at any one point in time may have a point prevalence of some sort of mental health crisis going on, from everything from an adjustment disorder because they broke up with their spouse or they lost their job, all the way up to a really serious mental health crisis. Not surprisingly, up to 80% of antidepressants in the United States are not prescribed by a psychiatrist. They're prescribed by a primary care physician. 75% of patients with depression see their primary care provider. Yet depression goes undetected in 50% of primary care patients. So again, a huge mismatch between identification and trying to attempt to address the problem of depression, even though a huge lion's share of patients will experience a major depressive episode at some point in time. And those who do receive care, especially in the primary care setting, only about 20 to 40% of those patients substantially improve within 6 months without some sort of additional specialty intervention. And this is probably the saddest, metric here, is only about half of patients were even referred to specialty care actually follow through with connecting with that mental health provider, whether it's a psychiatrist or a therapist. And those who do connect with a therapist, for example, on average, they only see a therapist for 2 visits before disengaging from care. And for those of you who are not mental health specialists, it's very difficult to resolve most mental health issues with 2 office visits, unfortunately. So what do we do? Where do we go from here? Well, how did we get here? What are these major barriers to accessing behavioral health resources? Because there are resources out there, right? One, the demand exceeds the available supply at this point with how we are currently allocating our resources. There's also a lack of systematic triage and a lack of low intensity first pass interventions for patients. Not every patient needs to see me as a psychiatrist. Most can probably get well never having to see me. But providing them access in the direction of where to go and also helping them resolve what is the true problem is not a trivial task. And so this is where things like big data and health technology infrastructure can really help support us in filling in gaps in the care continuum to help us better triage our patients and get them to the appropriate level of care, which again, as Zach mentioned, is not trivial and leads towards a lot of resource misallocation. Again, there's an absence of this care navigation support mechanism to help patients figure out where to go. And by the way, there's not a really great mechanism to get reimbursement for care navigation resources. So how do you fund that? And the current reimbursement model discourages insurance-based mental health practices in the community. Another sad fact, psychiatry is the lowest specialty to accept insurance across the United States. I think the last time I looked, about 50% of psychiatric providers accept insurance. The rest are cash-based practices, and they're full. So why would anybody try to take insurance under that current reimbursement model? So going back to why should we integrate physical and behavioral health care at all? Here's also some encouraging data, right? So behavioral health disorders have a high prevalence globally. Depression is now the leading cause of disability worldwide, so it's not getting any better. It's getting significantly worse. We know that mental health comorbidities decrease the quality of life. They increase your risk for worsening of a physical comorbidity, and overall, they increase healthcare costs. We also know that behavioral health conditions frequently go undiagnosed and untreated. I think it's really important to recognize that amongst our primary care patients, if you have at least one chronic medical condition, you are twice as likely to have a psychiatric comorbidity as a patient with a non-chronic medical condition. Those with 4 or more chronic medical conditions have 5 times higher rates of mental health comorbidities. Patient engagement and specialty referral is low. Patients receiving treatment from providers or prefer to have treatment from providers with whom they have an established relationship. They like their primary care providers. They don't like psychiatrists. And multimodal specialty treatment is costly, right? So how do we, what's the best approach to treating a mental health disorder? It's not just medications. It's usually medications plus some sort of psychotherapy plus some sort of social intervention. It's much more expensive to refer one patient to 3 or 4 different providers as it is to try to unify that care under one integrated and coordinated system. And just to, again, not belabor this point, but high complexity demands that physical and behavioral health care is coordinated. And mostly because patients who have high complexity, meaning they have a physical and a mental health comorbidity, even though they actually represent the smallest percentage of patients who present for care amongst most primary care populations, they occupy the most or almost the most healthcare cost burden in the United States. And so we must start wrapping around these patients and developing team-based approaches towards solving these patients' mental health and physical behavioral health needs. And getting on to the good news, right? There's synergistic benefits of having highly coordinated physical and behavioral healthcare management. We know that it improves medical and behavioral health financial satisfaction scores and functional outcome measures compared to quote unquote treatment as usual, which is usually ignoring the problem or trying to refer out. And take your favorite medical comorbidity, pair it with depression. If you effectively treat the depression, usually, for example, it can improve all sorts of symptoms in patients with terminal illness. It can improve outcomes and all-cause mortality in patients with, for example, coronary artery disease. And similarly, it can improve diabetes management. And from the primary care perspective, we love that, right? Let's carve out a subpopulation of our practice for diabetes clinic, but let's also add a mental health and a behavioral health component to that. Let's add a health psychology component to that. You'll get much greater return on your investment by integrating those 2 care pathways. All right, so I've talked a lot and we still don't even know what integrated care is. So broadly, we define integrated healthcare as a model of service delivery that combines care for physical, mental health, substance use disorders in some sort of coordinated fashion to address problems that are identified in the primary care visit. So portal of entry into care for a unified treatment approach, mind and body simultaneously. And the goals of integrated care are typically to do two things. One is to increase access for people for whom access has been challenged for all of the reasons that I've mentioned. So thinking back to why integrate care, it improves patient access. And it also improves the quality of care that people are already providing to their patients. Now, integrated care is not one thing. Integrated care is a philosophy. It's a model. There are many different ways that you can develop an integrated care solution, from very simple care coordination all the way up to a highly coordinated dance amongst a team-based approach like the collaborative care model. There's not one system that's better than the other. In fact, this has been going on since probably the 1970s. We've been thinking about this with the medical home model, CMHCs. All of these things are forms and fashions of collaborative or integrated care. I don't care what form of integrated care you use, but you can think through what works for your system, what's going to work for your target population, and what's going to work with the resources that you have at hand. And integrated care kind of follows some similar themes. So here's a table comparing different kinds of models of integrated behavioral health care. Starting on the left-hand side, we have things like coordinated care, co-located care, which is essentially park a physician, a PCP and a psychiatrist in the same building. They don't share an EMR, but just by having lunch together and being in the same building, they tend to refer patients back and forth to each other. To collaborative care, which is again a fully integrated care health service delivery model, all the way on the right-hand side to primary care behavioral health, which is really, again, a very robust team-based approach to mental health treatment, specifically for patients with behavioral health needs, oftentimes for patients with severe mental illness, schizophrenia, treatment refractory conditions. And so some of the themes that kind of come out are location. Where is care delivered? It also has a spatiotemporal component. When does care get initiated, and when do certain care team members come into place? How is communication disseminated amongst the care team? So do you share an EMR? Do you have opportunities to interact with co-team members who are providing coordinated care? What's the degree of communication between team members? Is it once a month, once a quarter, every week? The sustainability model, how you're going to get paid for these models is very different, right? For coordinated or co-located care, everybody's doing their own billing. We're kind of doing our own thing. Whereas under these more highly coordinated models, there might be some opportunities to have shared sustainability models and billing practices. And also each one has its own unique target population that it's looking to. And probably what's kind of obvious at this point, but there's a continuum. There can be integrated care models that are not very integrated, but integrated enough to very integrated and really robust care team models. Again, some are more expensive than others. Some are more challenging to implement depending on the scale that you're attempting to do this on. But there are many different ways that you can approach this issue. They all kind of share some core features, and especially when we're talking about evidence-based integration models. Many of them are greatest good for the greatest many, and they're predicated on population-based health approaches, meaning that you're doing things like whole population screening. So PHQ-9s for every patient who walks through the door, GAD-7s for everybody who walks through the door for anxiety, NIDA assists for screening for opioid use disorder in the primary care population. Pick a metric. Active case finding, and some sort of mechanism for an internal referral workflow for care. It usually involves a multidisciplinary team that also includes the patient. So we can't forget that the patient is probably the most important member of the team. It involves some form of care management. I don't really call it case management. I like to call it care management, but it provides some kind of support to address all of the other social determinants of health that are often neglected or difficult for us to impact in the medical model of mental and physical behavioral health. There are opportunities for systematic quality improvement, meaning that you are predicating your program on generating data and recursive problem solving. So it's not just set it and forget it. You need to have stewards of these programs. You need to have metrics that you're operating under to help you understand what you're doing. And you must have metrics that you can use in real time, all the way down to drive individual patient care, all the way up to driving population care in a mechanism that allows you to pivot very quickly. It also provides some algorithms for decision support based on all of this measurement that you're doing. If the patient's trajectory is not improving, it means you're not doing something right for the patient. It's not good enough to say, patient looks better. Patient says they're better. Well, are they better? How do you know? It also provides some mechanisms for self-management and care support, oftentimes by improving things like coping at home, self-directed, self-help solutions, developing problem-solving therapy skills. It also provides a mechanism for information tracking and exchange amongst providers so that it's not all predicated on a curbside consultation, right? There's formal mechanisms for communication, either through the medical record or other models or methods. And oftentimes it really benefits from a linkage with some sort of community-based social services, because inevitably collaborative care and integrated care solutions are wonderful for many patients, but they're not the solution for every patient. And so you can't be building bridges to nowhere, which is a really big challenge. So what do you do for the 2/3 of your patients for whom collaborative care is not appropriate? That's the hard part. Because what often happens and what I often see is you get population drift, meaning that the severity of cases in integrated care continues to get higher and higher. The burden and burnout gets higher and higher for the primary care providers, and you're diluting the quality of care that you're providing because you're trying to incorporate more and more services beyond the patients that you could possibly hope to help within the primary care setting. So that's really an important point to understand. All right. So going back to the Emory healthcare model, so the Emory Integrated Behavioral Healthcare Program has a true north. The mission of my program is to expand access to timely mental health resources. And when I say access, I mean access for both the patient through direct patient care services, as well as indirect resources for self-help, as well as access for providers to psychiatric experts. And this provides things like education and consultation, help PCPs help themselves and help their patients. And it's not trivial that these resources must be triaged for the appropriate level of care. This is a resource allocation problem. And the grand vision, which we're very far from, though, would be seamless entry, transition, and egress into a mental health resource from anywhere within the health system. That's my dream. Mostly for our patients, because I think they demand it and I think we're capable of doing it, but it's hard. The US health system is very heterogeneous. It's sort of a patchwork, a loosely connected patchwork of different resources. Navigating this is a really difficult problem. These are the core values of which the program is predicated on, and these are our true north pillars. Now, we are an academic institution, so I do lean quite heavily on the latter part of research and education. But we also want to predicate our programs on strategic growth. Anything I develop in the health institution cannot be built based on soft money and grants alone. It must have a sustainability component to it where we can make legacy programs that will be able to self-sustain over time. I don't care if we make money, but hopefully, and they must be cost neutral, which is really important to getting other stakeholders on board when you're trying to do integrated care solution implementation. And so here's what the roadmap of access solutions has looked like at Emory Healthcare. The first thing I want to implement and what we're in the process of doing is collaborative care. I consider it the gold standard of an integrated care solution. It is predicated on on-site evidence-based team-based care centered around the patient. Patients get access to care coordination and psychotherapy in the primary care practice, usually. The therapist and the primary care provider have access to a psychiatric expert through remote case consultation. We have interventions that can both influence both physical and behavioral health simultaneously, and there's a sustainability model. So we're going to dive really deep into this momentarily. But in addition to this, we don't have the infrastructure or the resources to put collaborative care in every practice. And so what do we do for practices that don't or can't have collaborative care, at least all up front? We've developed a program called Interprofessional e-consults, which is essentially a way to formalize the process of the curbside consultation. While I have many friends in primary care, not every primary care provider is my friend. And I want to give everybody the opportunity to pick my brain and get access to what I think would be the next most appropriate step for their patients with respect to psychotropic medication management. And so we've made a mechanism within our electronic medical record system so that way we can formalize that curbside consultation process. By the way, there's billing codes for this, so we can generate revenue in order to do this program. And it also makes any recommendations I make formally part of the electronic medical record system so that anybody in the health system can implement them. And the last thing that I'm working on is how can we leverage mHealth infrastructure and technology to further fill in gaps in the care continuum? Can we use it to, for example, provide low intensity solutions, self-help directed resources for our patients? Can we use it to supercharge our collaborative care efforts and expand what our caseloads are traditionally for our care managers within the collaborative care model? And can we also generate data where we can better understand how to triage and stratify patients within the health system? So these are the roadmap or the access solutions under the integrated care umbrella that I'm currently developing at Emory Healthcare. But now let's dive deeply into the collaborative care model. Oh, and just taking a step back. So the hope with all of these integrated care solutions is that we're going to take this one-to-one referral model that doesn't work, and we're going to reshuffle the deck. So the idea is to develop an ecosystem where patients can essentially self-stratify from primary care, where we can get most patients with mild or moderate depression well within the primary care practice. Those who sort of rise to the top will have a direct referral to psychiatry, for example, for specialty care resources. But also, I need to redraw this because those arrows can be bidirectional. Meaning that once I get my patient better, our patient better, I should say, I can send them back to primary care on a stable medication regimen so that they can continue to renew the medications and so that I can take on and consume more patients and more care. Okay. So what is collaborative care? Spent all this time setting up integrated care and what it is, and we haven't even talked about what it is. So the collaborative care model, as I mentioned, is a team-based approach centered around the patient. So this circle represents your favorite primary care practice. And it involves 3 core team members. First is the primary care provider who serves as the team leader. They're going to be the person who identifies the patient as having a psychiatric or mental health concern. And they're going to refer the patient internally within the clinic to the collaborative care program. Oftentimes, we like to do this via warm handoff, meaning physically walk your patient down the hall to meet the therapist to destigmatize the process, make patients more comfortable with seeing, oh, I can work with that person, right? When they hear therapists, all sorts of things come to mind, right? The PCP is the prescriber. So this is not handing off your patient to a psychiatrist within the practice. The PCP is an active prescriber within this model. But also they're reaping the financial revenue rewards because the PCPs are the billing providers under this care service model. We'll talk a lot about the billing in a second, but this also has some other advantages to the patient in that the mental health treatment that they receive under this care model falls under the medical benefit. So these CPT codes are not billed under a carve-out for the mental health benefit. The behavioral health care manager is a new position that may be unfamiliar to you, but this is an on-site mental health or behavioral health specialist. We'll talk about what that role could look like, but they are the linchpin of this whole thing. So they enroll a patient in collaborative care. They do a psychiatric evaluation and help revise the diagnosis. They also provide on-site brief psychotherapeutic interventions. Think behavioral activation, problem-solving therapy, CBT for insomnia, CBT for anxiety and depression. They are also the masters of data. So they manage a registry, which is actually a required and core component of the billing model that we'll talk about in a second. But really that helps us understand how our patients are doing from both an individual patient level to a population level in a very efficient manner. And they are also the masters of communication amongst the care team. They relay information from the patient to the PCP. They relay information from the psychiatric consultant to the PCP. And then the psychiatric consultant role, access to the psychiatric expert. Their role is to have weekly meetings with the behavioral health care manager. They do whole population registry review. So they're helping the care manager think through their whole patient population, who's getting better, who's getting worse, who's ready to graduate from collaborative care, because we want patients to get better and off the caseload. They also provide individual case consultation for patients who are stuck, who are having a side effect or an issue. And they also provide provision of some sort of formal recommendation within the electronic medical record. You'll notice that there's no arrow pointing directly between the patient and the psychiatric consultants, because in this model, they do not see the patient. This is how we scale me as the psychiatrist, because I can spend an hour and a half and do a whole caseload review with a care manager, review 10 to 15 cases in an hour and a half, more than I can ever hope to do by seeing patients individually within one primary care practice. And so if you distribute 100% of me across multiple primary care practices, I can impact a lot of patients without actually physically seeing them, just based on the information that I receive from the care manager and what I can glean from the electronic medical record. This is the core model. And a little bit about the care team composition. So the primary care physician is the treating billing practitioner. It can be a physician or a non-physician practitioner, either a PA, NP, any other licensed health professional. And also, interestingly, it need not be a traditional internist or GP. So you could adapt this model for cardiology or for a palliative medicine patient population for whom, a lot of those patients see their palliative medicine physician as kind of their core PCP. So the codes and the way that you can bill for this model are actually really flexible from that perspective. The beneficiary is a member of the care team. Okay, patient-centered model, sounds good. And this last point is also very important to understand. So it really gives you a lot of flexibility for whom can be amongst the care team. So from the perspective of the behavioral health care manager, we think about people like licensed mental LPCs. We think about LMFTs can serve this role, LCSWs. You can have a really enterprising and psychologically minded nurse serve as the care manager and give them ancillary training on providing brief psychotherapeutic interventions. You can hire a bachelor's level person just out of undergraduate who's taking a couple of gap years and train them on highly coordinated interventions. You can hire a clinical psychologist or a PhD level psychologist to serve in this role. Clearly, one thing that you can think about is a bachelor's level or undergraduate level behavioral health care manager is probably a little bit more cheaper than a clinical psychologist. But again, the degree of expertise is quite different, and what you can do with that individual is quite different. But the codes allow you to have a lot of flexibility with respect to who serves in that role, which is great from an implementation and a resource perspective. You can repurpose and use what you got or use what you can afford in order to get this model up and running. It also doesn't require that these providers are employees of the practice. They can be outside contractors. They can be consultants. They can be an out-of-the-box telehealth psychiatry company. There are companies, in fact, that do out-of-the-box collaborative care. They'll come in, do all of it through remote telehealth or telepsychiatry, and give you all the documentation to allow you to submit the bill. So there are mechanisms in order to do that. But certainly a lot of this will depend on your individual state and how independent practice guidelines are governed within your practice. But this is just to say that there are many different ways you can implement this model, which is good. Few points on the registry piece, because this is kind of probably a new concept maybe for some folks, is that not only is it invaluable, but again, it's a required component of the collaborative care model. You must maintain some sort of database of all of the patients that you are managing in a collaborative care panel. And it has several key functions, which again are really indispensable for providing really efficient care for your patients. First, it helps you track patient level and population level clinical outcomes and treatment events. So in one document, I can see when a patient was enrolled in the program, how long they've been in the program, when their most recent visit to the program was. I can see what their baseline depression score was, what their most recent depression score is, what the trajectory of care is. I can see all the medications that they've tried over the course of an episode of care, so I can provide good recommendations to the care manager and the PCP. The care manager can also see, how good am I doing amongst the 100 patients that I have on my panel? What's my response rate? What's our remission rate as a team? So you can really see on the fly, you can do quality improvement without having to do all of this retrospective data analysis. And we use this data in real time. Every week, I'm reviewing our dashboards and I'm reviewing our registries. It also prompts measurement-informed treatment to target, meaning you must have a goal in mind for the patient population for whom you're treating. For depression, we often think about response and remission, and response has a very clear definition in the literature. 50% reduction in symptoms on some sort of validated scale. That can include the PHQ-9. It also facilitates efficient case reviews. So again, instead of me having to dig in the electronic medical record for individual patient data, I have a really nice document where I can go in, or a database or a dashboard, and evaluate what's going on from, again, population to patient with 1 or 2 clicks. And it also allows me to track productivity and quality of the population-based management. So for example, what percentage of the patients in the program have completed an assessment? It seems trivial, right? But really, I want 1 metric per month. How efficient is my care manager, or how efficient are the workflows that we've developed for the care managers in order to capture that data? If only 30% of my patients in the population have a follow-up PHQ-9, that's a problem. But knowing that is also really important. And it provides opportunities for us to discuss, well, what are the challenges? How can we improve this? And it's also critically important for billing. And I'll talk about this in a second, but the billing model here is not easy. It's predicated on minutes, so keep that in mind. And what constitutes a patient registry? I'm going to skip this slide just for the interest of time, but it can be as simple as a secured Excel spreadsheet that everybody has access to. It can be something that you develop with your IT resources and live in the cloud. It can be something that is available from, for example, the University of Washington AIM Center has a product that is very reasonably costed that you can use. That's a cloud-based registry that is used in most of their clinical trials. Or you can go whole hog and build a real fancy EMR-driven registry that has a lot of advantages because it will automatically pull in data from your EHR, right? Which is nice. So you don't have to spend time copying information into a separate spreadsheet. It's all going to be auto-populated, but that requires a lot of cost and upfront IT investment. And so what does the collaborative care look like from the patient perspective? And we think about collaborative care not as this never-ending process, but really as a treatment episode. It's phasic care. Starting from the left-hand side, patients are identified through population screening, and you can set that target based on your favorite patient population. In most of our clinics, we've set a PHQ-9 or a GAD-7 greater than or equal to 10 as our baseline to consider for referral. We do have exclusion criteria, right, for our patients within our primary care practices, but that can be up to you about how you design that within your workflows. The PCP uses that screening data to identify that the patient has a problem. They do their own assessment and determine that the patient is a good candidate for collaborative care based on a priori agreed upon inclusion and exclusion criteria. And again, they refer the patient internally to the collaborative care program by either marching the patient down the hall to meet the care manager or through some sort of internal referral mechanism through EHR communication or email. The care manager meets with the patient, makes sure again that they're a good fit for the program, does an intake, and then they begin the phase of care. And I think about the phases of care kind of on monthly cycles. The care manager is going to meet with the patient and provide provision of a blend of that care management and psychotherapy. If medications are indicated, they're going to help the PCP monitor for things like side effects, monitor for adherence to medications, and also help report back if the patient is doing well with the medicines towards things like titration. So making sure that we're titrating not every 3 to 6 months, but every 2 to 4 weeks, which is really standard of care with antidepressants. They're also going to meet with the psychiatric consultant every week to talk about their caseload. And again, we're reviewing data every week and trying to treat to target. And then at the end of the month, really the first week of the next calendar month, we're going to add up all of those little minutes that we spent as a care team providing provision of care for patients, and we're going to drop a bill. So you're not dropping a charge every time you see the patient. So that is one of the biggest challenges with implementing collaborative care, is making a workflow and a mechanism to deal with that administrative burden. And we do this for about 6 to 12 months. Can be longer, can be shorter. It's tailored to the patient's needs and what the patient's goals are within the collaborative care model. If we can't get your patient better in 6 to 12 months, there's the no money back guarantee. No, we graduate your patient. We don't call it discharge or referral. We graduate you from the program. The program was not helpful for you. You got what you needed out of it. We're going to either refer you to a higher level of care if it's appropriate, or if you got better, we're going to graduate you back to the general primary care population. You're not really going anywhere, right? You're still going to see your PCP. And we're going to develop what's called a relapse prevention plan for you. What are you going to do should you notice that your symptoms are coming back? How are you going to try to manage that on your own? Can you come back to collaborative care? Absolutely. But we prefer that you went about your life and didn't need us if possible, right? Greatest good for the greatest many. We're really not trying to keep patients for a very long time. There's about 100 patients that we want on a caseload for a moderate sized clinic of about 5,000 to up to 12,000 unique primary care patients. So we're juggling a lot of balls in the air. And again, brief interventions. We're not talking about hour-long, psychoanalysis 5 days a week. What we're really talking about is increasing the number of contacts with your patient through that care manager mechanism without increasing the burden on the primary care provider. So over an episode of care, you'll notice that the PCP on average will meet with the patient once or twice. So not much more than they ordinarily would probably if they were prescribing an antidepressant anyway. But what you'll notice is that there's all these other contact points with the patient through that care manager who's relaying information. And again, we're scavenging minutes through that communication. The PCP can be remotely titrating the medication without having the patient come in for an office visit. But by the way, the PCP can also still bill for traditional E&M codes for doing med management and all those other things, and still reap the rewards and benefits of billing for the collaborative care codes, as long as you're not double dipping in those minutes. And again, we're getting those psychiatric consultant case reviews. Usually for most patients, it's 2 reviews over a course or an episode of care. And this is a really scary slide, but again, as I mentioned, we tabulate all the minutes that we're spending. So for example, when I'm doing my caseload review with my care managers, we'll talk about a patient and I'll say, okay, we just spent 15 minutes talking about Mrs. Smith. Okay, we just spent 5 minutes talking about Mr. Jones. Log it. And I put it in my note. And again, we're adding up all those minutes until at the end of the month, we can then drop a code. In the light blue on the right-hand side is the suite of collaborative care CPT codes. We'll dive into them in a second. A couple things I just want to point out. The minimum code, for example, is 16 minutes worth of care over the course of the month. The maximum you could potentially reap the benefits are of 106 minutes. This is because there's this follows the Medicare time rule. So you can drop these codes for half of the maximal minutes. There are add-on codes, but essentially what I'm trying to point out here is that, again, you're not getting any additional revenue for seeing the patients a lot. So it really tries to incentivize you to, again, see many patients and generate many bills as opposed to focusing on a core group and just generating tons of minutes for your individual patients. Very similar to the chronic care management codes, if you're familiar with those. And so how well does collaborative care satisfy the integrated behavioral health mission at Emory? And philosophically speaking, well, it's evidence-based. It's incredibly effective. We'll talk about the over 80 RCTs that have demonstrated amongst various patient populations that it's an incredibly effective system of care. It's timely because you're treating the patients where they're most likely to be seen and captured, right? You can walk a patient down the hall and introduce them to a therapist. I don't know any other mechanism or model of care that allows you to do that. It's built on being flexible. Care managers have time built into their schedules to do nothing but sit there and wait for patients to come in, and use that time to do administrative work, use that time to do proactive outreach and call your patients, which generates minutes towards billing, right? And it's synergistic, right? Can't treat the body without the mind and vice versa. It's scalable. One clinic usually can manage about 100 collaborative care patients at any given point in time. At any given point in time, about a third of your patients are new to collaborative care, a third of your patients are going through active treatment, and a third are going through what we call the relapse prevention phase, where you're really trying to ramp down the amount of time you're seeing them, maybe a brief phone call every month, or maybe one visit per month as opposed to once every other week when they're first starting out care, and you're getting ready to graduate them. That's where, again, the metrics are so important and the registries are important. How many patients do I have in these different buckets and phases of care? If you have no intake volume because the referrals are so high, you need to think about your target population and what are you going to do for these people for whom are waiting 2 or 3 months to get an intake in the collaborative care model. That's a problem. And lastly, it's sustainable because we can bill. Because CMS and all of the advocates really pushed to get a billing model that is supported by CMS for this care service delivery model. So let's dig a little bit into the data. I told you that there's like 80 RCTs. We're not going through 80 RCTs, but probably one of the, landmark studies was the IMPACT trial, which stood for Improving Mood, Promoting Access to Collaborative Care Treatment. It was a multi-center RCT of about 1,801 depressed patients, older adults. So it was really looking at a lot of late life depression that were randomized to this very coordinated collaborative care model with all of the elements that I talked to you about versus treatment as usual. And by the way, treatment as usual, even in one of these practices, involved one practice had a health psychologist embedded in there. And what you can see from this graph is we're looking at the percentage of patients who had an improvement in their depression scores over a 12-month period. Gray bars are the treatment or the intervention arm. Blue bars are the treatment as usual arm. You can see the gray bars across all of the clinics are about twice as tall as the blue bars. Twice as many patients got better in collaborative care versus treatment as usual. And this number, twice as likely to get better, has carried over to like almost every RCT that's been done for collaborative care, which is so interesting. It really does seem to be head and shoulders above treatment as usual for patients who get involved in treatment. And the IMPACT trial, as they talk about it, really achieved the triple aim. It improved patient outcomes. When we did all sorts of surveys, they were less depressed. Because these were older adults, they had less physical pain, better psychosocial functioning, better quality of life. Patients and providers were so much more satisfied with the care that they were getting when you did qualitative assessment and qualitative surveys. And there were massive healthcare savings. What was really interesting is the intervention was for only 12 months, but they continued to survey. I mean, the programs kept going, but they continued to survey what the health savings were after 4 years. And the savings were remarkable. They determined that they got about $6 back in long-term care costs for every dollar they spent on implementing and sustaining the collaborative care model. Now, there's been a lot of other studies that have tried to look at the economic impact of this, and it's really hard to summarize this because it really depends on so many different factors. What is the constitution of your healthcare system? Are you an FQHC? Are you a value-based care organization? Are you an academic health center, which is just focusing on fee-for-service, which is incredibly inefficient because you have a blend of all sorts of payers, right? It's really hard to kind of extrapolate what the potential cost savings are. But no matter what study you look at, there's an economic case that collaborative care will save your institution money and it will save your patients money on healthcare resource utilization costs and also save you from things like high provider turnover. It'll save you from leach or loss of patients to the community, right? There's all sorts of these synergistic advantages. Those things are hard to show within a health system. So when you're doing collaborative care, it's not for the faint of heart. Don't expect to be making money, but you can make money if you do it at scale. So that's something that's to keep in mind. Not saying that we should do this to make money, but you can. as I mentioned, 80 randomized RCTs looking at this. There's several meta-analyses out there that you can go access. And again, consistently more effective than care as usual. And it works for diverse patient populations. It works for perinatal patients. It works for adolescents patients. It works for geriatric patients. It works in rural communities, low middle income countries. It works in FQHCs. It works at the VA. It works everywhere because it's so flexible and because it's so predicated on the stakeholders, which include the patients and the populations that you're serving. And really, most importantly, it improves outcomes across racial and ethnic populations. Again, whether you're white, Black, Latino, underserved patients who rarely get connected with mental health treatment get much better under this model of care. So these are the reasons why we really should be doing collaborative care and doing integrated care. Just a quick word on the potential impact for rural communities, because I know that's of interest here in Oklahoma. Again, collaborative care is effective for patients in rural communities. It's been demonstrated for adults and late life depression, bipolar disorder, PTSD. An interesting theme across trials has been, it's so hard to find local providers, right, or local care managers. And so a lot of the rural implementation efforts have really looked at using remote and telehealth services, which has been demonstrated to be not only effective and viable, but acceptable amongst our patients. I think, fortunately, one of the good things to come out of the COVID-19 pandemic is that patients are really comfortable with telehealth services. And in the mental health space, they actually prefer it. It's more convenient, it's more efficient, and generally speaking, you can get pretty good care without physically seeing the patient with mental health services. It's tractable for that reason. You can collect data remotely from patients. You can collect data asynchronous from office visits. You can call them and get surveys and questionnaires. And so remote and decentralized collaborative care, as it were, is a viable way to do this. Yes, the warm handoff is great and it's nice, but if you're not resourced to do it, you can think of these out-of-the-box decentralized models, or decentralized with respect to the primary care practice or where the patient population physically resides. And there was a really nice large study to promote innovation in a rural integrated telepsychiatry, so the SPIRIT trial. I won't go through all of these points here, but this is just to say that it can work, but it's hard. And there are other challenges in doing collaborative care here, because what, again, do you do with those patients who need more resources? These programs tend to be really challenged with respect to urgent crisis resources for their patients. They're also very challenged when you decentralize the model, because let's say you have multiple health systems that you're serving, they're all on different EHRs. Or if you have a care manager and a psychiatrist that's trying to work across multiple health systems, now I got to get credentialed in 5 different health systems in order to do collaborative care. So these are some of the systems barriers that really make it hard for us to do things like decentralizing the model. Not insurmountable, but they do take a coalition of folks to also break down some of these barriers to make it so that we can rapidly implement these things. The potential economic impact for integrated behavioral health is massive. It's hard for me to, again, judge or tell you what this is going to look like within your health system or model, because they're all different. You need to do your own financial analysis to figure out what's going to work for your system, your population, who's paying, where are they paying, right? Is this an FQHC? What's the care population? But my favorite data to date about this is a white paper published by the Millman Research Group, which they're an actuarial group. And essentially what they looked at is, through market scan analysis, what the total impact of any kind of integrated care for mental and physical well-being across commercial Medicare and Medicaid payers. And they estimated that if we did robust efforts, it could save between $37 and $68 billion nationwide. I mean, massive health savings, which amounts to somewhere between 16 to 28% of all current healthcare costs for mental health patients could be saved. And really, actually, one of my favorite quotes from this is they looked at the annual wages of all of the psychiatrists and psychologists throughout the country. They made an estimate saying that, let's say for all of the wages of all the psychiatrists in the country, it's about $7.5 billion per year, $9 billion in annual wages for psychiatrists. The impact of integrated care can be up to 2.3 to 4 times the annual earnings of all practicing psychiatrists and psychologists combined. Even if you doubled the number of psychologists and psychiatrists, it would still be more impactful to do integrated care and cost savings, even if you hired more and generated more salary revenue based off of that, which I thought was a really interesting statistic to look at. And some people ask me, well, how much does it cost to implement collaborative care? Because you're not billing day one. And not only that, you're delaying billing by first month of day one, right? Because you bill at the end of a calendar month. Again, there's not a good number out there, but actually one of my favorite data sets comes out of the oh my gosh, what is this group? The Meadows group. They're the Meadows Policy Group out of Texas, University of Texas. And they did a survey of 10 large health systems across the United States, looking at what their implementation costs were, and they stratified it based on the size of the systems and the size of the implementation. And so essentially what you can see if you look at the bottom line where it says overall costs per clinic, it can be as low as a $50,000 initial investment for a small clinic, all the way up to, you know, $500,000 to $1 million, depending on the scale that you're implementing. But we really look at the end of the day, that's not a lot of money, especially for a large healthcare system. But it does require that you have a lot of infrastructure costs up front to get the ball rolling. And that can be a real challenge for implementing care if you don't have those upfront costs established. You can certainly repurpose personnel within a healthcare setting, but it does require a substantial amount of infrastructure support early on to make sure that you have all of the components in place to do this highly coordinated care. And this is the reimbursements. So these are the 2019 Medicare reimbursements for the different flavors of collaborative care codes. Medicare covers these codes. I will say most commercial payers cover these codes, and in fact, they usually reimburse better than Medicare codes. Medicaid, however, is on a state-by-state basis. I might need to move to Oklahoma because Georgia Medicaid does not cover collaborative care codes yet, and I am aware that Oklahoma Medicaid might be or has approved, turned on the codes, which is great. But caution beware, reimbursement rates vary widely across payer and where you are in the country. But the good news is, again, most payers want to incentivize you to do this. And so there's a lot of room to negotiate with payers around rates, negotiate around getting grants for infrastructure from the payers, commercial payers, believe it or not. And really interestingly, some states are really going whole hog on this. North Carolina Medicaid pays 120% of the Medicare rates. When did you ever hear that state Medicaid is going to reimburse better than the Medicare rates for something ever? So they got good lobbyists in North Carolina, but there are ways to incentivize folks around doing this to at least make the infrastructure and implementation costs more palatable early on. These are different components of the care codes. We don't need to necessarily belabor this, but just a few things to be aware of is that per CMS recommendations and guidelines, you must have all of the core team members present. You must have a registry. You must have regular weekly case conferences. Those are non-negotiable to use these codes. The patient also has to provide general consent for services. This sounds a little weird, but my PCPs have to consent the patient to collaborative care, not because it's research, but because they're going to be incurring costs that they may not physically see. So for example, care manager talks to me, the psychiatrist, 15 minutes. Patient wasn't involved in that care. Patient just needs to understand what the model is and what their potential costs are and how we're going to be billing their insurance for this. There may be copays for most of our patients with respect to collaborative care, but I often sell it to patients. I'm like, look, it's one-stop shopping, or I can refer you to a psychiatrist who probably won't take your insurance and a therapist who probably won't take your insurance, and you can pay either out of pocket or pay more money to see your PCP and 2 other specialists, or we just do it all in-house and you get it at a discount. And most patients are totally okay with it. They understand the value of this. It's uncomfortable for most primary care providers to have this discussion, generally speaking, because physicians are terrible with money and they don't like talking about money with their patients. But unfortunately, under this model, you do. So that's something that does require a little bit of coaching when you're thinking about how you're going to implement this model. And again, the way that we bill is we calculate how many minutes the whole team spent every month. And then at the very beginning of the next calendar month, we bill for the previous month's services. So there's a delay a little bit with respect to when reimbursements are going to be coming in. So when you're doing your cost benefit analysis and when you're doing your business modeling for your healthcare institution, it's really important to understand that there's probably going to be a lag compared to other health service models with respect to your return on investment. Generally speaking, it takes a year or two, maybe 3 to get to cost neutrality. If you're doing really good with a good payer mix, it takes about 5 years to see real true return on investment, or at the very least, the cost savings that you can see nationally. So it's not a quick game. This is not a sprint. It's definitely a marathon. So what is the current state at Emory? Just to highlight that you can do this rapidly. Again, I joined Emory in July of 2020. Since joining Emory, we are now in 4 large primary care practices amongst the 100 that I mentioned at Emory Healthcare, but we're covering about now up to 40,000 primary care patient lives. We've done over 1,500 patients engaged in an episode of care. We've billed $1.8 million in charges. That's not what we get reimbursements, but we've done a lot of collaborative care. We're on the road to cost neutrality. We've done this tiered implementation. We've used it as a vehicle for not only education, but research by participating in a clinical trial, trying to see if collaborative care is an effective strategy to manage opioid use disorder in primary care. Part of that included implementing a whole new screener into the clinical model. If you've ever tried to do any change within the primary care practice, including implement some sort of a screening assessment, you know how impossible that is. We were able to, in 6 months, implement an OUD screener and get the medical assistants on board to do it and get them to report to the PCPs that we had a patient who came in who, unbeknownst to the whole care team, was misusing their opioids or using heroin. I mean, you know. The e-consult program is up and running. We're in the pilot phase and we're beginning to ramp up advertisement for this, but the model and the workflow works great. And we're now in a partnership with a third-party vendor called NeuroFlow, which is an infrastructure and health platform that has a patient-facing app. They can serve as the registry. I'm not going to talk too much about this unless people are interested offline, but that is to say that we're now trying to leverage technology in order to, again, supercharge all of these efforts that we're implementing in the integrated care ecosystem at Emory. And here's what our practices look like by the numbers. When I picked clinics to start the collaborative care model, I intentionally picked clinics that were very different in composition. Yes, we are all Emory Healthcare clinics, but no 2 clinics are the same, probably similar in your institution. We have family medicine practices that have a large Medicaid patient population. We have faculty and non-faculty primary care practices that are hospital-based. We have a practice that's a relatively moderately sized community-based practice. It's working in all of the models. Productivity is a little bit different in each clinic. The flavor of the kinds of patients that come in is a little bit different. The SES of patients in those clinics are different. But demonstrably, we've done our own mini clinical trial and shown that we can do this in Emory, even though all of these clinics are so markedly different and in different geographic parts of the city. Remarkably, about 75% of the patients have never had an engagement with a mental health provider before. So we're hitting good access. Our depression response rates are about 31%. That may seem low, but I haven't stratified this based on severity. We're pretty liberal with who can get into our collaborative care program at the moment because we wanted a quick ramp of caseload to help generate that billing model and like get some data around what this looks like. But if you look at things like the STAR-D trial, 30% response rate's actually not too terrible and not quite off the target for what we would expect for patients to respond in the primary care context. And we have a 32% anxiety improvement. Again, based on psychometrics alone, not stratified based on comorbidity or anything else. Mentioned the revenue generation, we're able to bill and we're able to get reimbursement, which is really critically important. And again, I talked about sort of the OUD screening at Emory. All right, so the things on your mind. I've gotten you all convinced that collaborative care is the best thing since sliced bread. You want to do it. how are you going to do it? The first thing you all must do is mentally ready yourself for change and prepare your institution for change. And so I really like John Cotter's 8-step model for preparing you and your health system for change. This is a tried and true evidence-based model. You can tell I'm pretty enthusiastic, and that's really where you need to start. You have to establish a sense of urgency and enthusiasm for doing this work because people are going to groan. And especially in my health system, uniquely, I'm a psychiatrist who's driving this effort. I'm coming into your primary care practice and telling you a couple of things. The first thing I say is there's no referral to psychiatry. So consider it persona non grata at our institution. You're on your own. So what I have to offer you is I can help you better manage your patients. I will be here every step of the way. I will help you manage your patients. But this is what we're doing. This is what I got. If you're not interested, you're not ready, that's fine. We're going to move on. And we can circle back to this. Oftentimes, once I show you what, your PCP buddy in the clinic next over gets when he does or she does, implement the model. But making sure that everybody is excited and on board and understands the urgency for this is really going to help light the fire under your institution. And that can come from any direction. My coalition of stakeholders are an enthusiastic me, which is an implementation champion. I've got a core group of primary care champions. I call them champions because they really are the champions. Even if the entire clinic, for example, one of our clinics has, 12 or 13 providers, even if 5 or 6 of them are enthusiastic and the other 5 never refer me patients, that's fine. There's enough business to go around. You just need a critical mass of people within one population in order to come on board. You don't need every primary care provider to be jumping for joy and wanting to do psychiatric med management. Because again, there's this spillover effect. Once they see what, their partner in the treatment room next door is doing and the work reviews they're generating and how much easier it is to manage patients with depression or other chronic medical conditions, oftentimes they'll begin referring. You need to build a coalition because you're not going to do this on your own. You need leadership to be involved from whatever level it is. C-suite, department chairs, clinic leads. You need administrative leads. You need IT experts who are going to help you with analytics. You need pop health experts. You need revenue cycle, and you need financial services people. I have excited stakeholders in all of those different categories. I found the one biller in my insurance, in our patient financial services who was like, she's like a code nerd. And she was so excited by the notion of like, oh, we're going to do this new code thing. And that's how we drummed up interest. And also, the business of medicine is about the relationships, right? Every one of our stakeholders had some instance in their own personal life or experience where mental health touched them or a family member. And also that really helped bring everybody on board and understand why we're doing this and for what we're doing it. You need to establish your transformation team and establish them early. And this team is going to look different at different phases of care and phases of your implementation process. So when you're planning, you're going to be capturing all of your data, doing your needs assessment, understanding the impact of what collaborative care might have for your patient population, and you're going to develop a business plan with staged goals. You're going to understand what resources you need, what resources you have, and who are going to be the good partners down the road when you're actually putting rubber to the road and getting into the clinics. So the team members at this phase are usually kind of higher level people who are consultants thinking about it. Again, an implementation champion always helps. And that can be anybody. Once you're getting ready to build the infrastructure, you're going to develop the workflows, you're going to develop the operational units that are going to help deliver this. You're going to contour the patient populations through either active case finding or through, prospective screening efforts. You're going to design how referrals are going to work, maximize efficiency from everything from implementation and documentation all the way down to data management and billing. And these are the proposed team members who are going to be involved. Again, operations leads, You're going to start folding in your IT experts. You're going to get your health informatics, data analytics, and revenue cycle people on board, human resources, because you got to hire. How are you as a PCP going to evaluate who's going to be a good psychologist or a good behavioral health care manager for your program? And eventually you're going to launch. You got to start somewhere, start anywhere, start small, start large, doesn't matter, but just get started. But also have a plan for maintaining your program. You need to monitor and improve your workflows. I've gone through several iterations of workflows in my practices. We survived an EMR transition. We went from Cerner PowerChart to Epic in the middle of our implementation, which was a boon because I got to sit in there and design the EHR for our workflows from soup to nuts. So actually it worked out really great for me. Most people would groan and think that it's going to be a big problem, but we took it as an opportunity to improve our efficiency. And again, you have to be recursively monitoring to prevent population drift. Because what happens is primary care providers, can't you see my patient with a PHQ-9 of a 4 and a GAD-7 of a 2? No, we can't. Because I got 50 other people with PHQ-9s of 27s and GAD-7s of 15s. But you can get your patient started on meds and see how they do. If they get worse, you can refer them out. Or I started this guy on Depakote for bipolar disorder, and I'm referring him over to you for collaborative care, for psychotherapy. We're doing this? Are we treating bipolar in your clinic? The answer to that can be yes, but understand that I'm going to be asking of you to do many other things, like a Depakote level every so often, a CMP every so often. I mean, this is not a set it and forget it. You're taking on the responsibility. So you as a primary care provider are not prepared to take on everything that's involved in caring for that patient population. It's best we not refer that patient to collaborative care. Are we going to do OUD? Are you prescribing buprenorphine for your patients? Yeah, you want to? You can, right? The DEA just did us a wonderful favor of ditching the X license waiver. Every PCP now can prescribe buprenorphine and MAT for your patients. It's a great, great strategy for patients with chronic pain. We can do it. But remember, you're the one who's driving that care as the primary care provider. So understanding the impact of that is really important. And I sometimes have to realign, the clinics back to understanding who's the core patient population and who can we serve and who is best served by a higher level of care. And the other thing you'll notice is that there's a throughput here of this implementation champion. It helps to have someone like me sort of overseeing it, but it need not be me. The clinical ops lead can be the implementation champion all along. It could be an enterprising nurse. It could be a social worker who's driving all of this. I've seen it all at all different other healthcare institutions. You just need the person who's excited and who wants to spearhead this effort. Henry Chung's group at the United Hospital Fund has a really great paper, a white paper on advancing integrated behavioral health into primary care. They have all sorts of phenomenal resources that you can look into, including a checklist for thinking through implementation of behavioral health integration. I really would recommend that you go take a look at that. And here's a list, this has actually been studied pretty closely about what are the facilitators and barriers to sustaining collaborative care implementation. And this is looking at it from the healthcare system perspective. So things that tend to help are strong patient engagement. So if your patients aren't sticking with collaborative care, there's a problem there. Point of for intervention. Having adequate staffing and low turnover certainly helps. If you're constantly having to hire new MAs that you have to retrain to do the PHQ-9 and GAD-7 over and over again, it might make it really hard to get your good quality metrics, at least from the screening perspective, and it might lead towards low ramp up for your collaborative care caseload volumes. Training for when inevitably a care manager decides to go on to greener pastures or open a private practice or do something else, right? So how are you going to accommodate for turnover within the collaborative care program? Misalignment between what collaborative care is and isn't amongst different stakeholders is always a death sentence for programs like this. Inability to leverage funding sources. So again, predicating or starting a service just on soft money alone and not having a good sustainability plan long term. That's often a time when budgets get thin. Things like this are usually often the first things that get cut. And so making sure that you have your own sustainability model in place, that way, should that come, you have your own funding stream to help support programs like this. and a lack of accountability and feedback. So again, this is not a set it and forget it. This needs constant auditing, constantly, caring and tending to it in order to get it to be operational. And over time, it needs a lot of oversight. The barriers on the right-hand side are sort of the inverse of a lot of the things I just mentioned, but that is to say that there are a lot of things that can impede successful sustainability of the collaborative care model. And so it's important that when you're thinking this through, you really take those things into account and try to address them when you're in the plenary phase. Anticipate what might be major barriers in your health system or your organization. Okay, with that, I'm done. Hopefully I didn't run too far over. I'm sorry. I like to talk, as you can tell. But here are some helpful resources for people to access. The University of Washington AIMS Center, the Advancing Integrated Mental Health Solutions Center. They are the world's foremost experts, in my opinion, on this subject matter. They're the ones who conducted the IMPACT trial. They publish most prolifically. This is where a lot of my integrated care mentors come from. They have tons of resources from training to financial modeling workbooks, Excel spreadsheets where you can plug your numbers in and see what it might look like from your health system perspective. I conducted a national forum at the PsychU National Forum where we had a really great collection of experts come and talk that's been recorded. You can take a look at. And AHRQ has something called the Integration Academy, which is also a really nice place to get a primer on integrated care. Again, has a lot of the similar resources, but in a slightly different flavor from their perspective. And lastly, training pipelines. How do you get trained to do this? So the American Psychiatric Association has developed some CME courses that you can take online. They're geared towards not only psychiatric consultants, but also they have CME credits for primary care providers to get oriented to the model and to understand how to operate in the model. And they also have training resources for behavioral health care managers, because what you're going to find in the workforce is nobody's been trained to do collaborative care. Nobody has any idea about what this is. So you're going to have to probably train somebody who comes from more of a more traditional psychotherapy background in order to operate in this position. Or you might have to take somebody who's more in the case management social work realm and tune their psychotherapy skills up. This resource is a wonderful resource to help orient everybody and get people on the same page about what each of the care roles are in this care model and how you can work as a team in order to do that. There's also a lot of access to consultants out there who can do this and come into your health system and help you with implementation. Just reach out and ask. So with that, I'll stop, take questions.
Brandon, thank you so much. And I'd like to invite, I've asked two people who are actively involved in our primary care areas in Oklahoma, who have tried, I think, their best to do some of this integrated care. Dr. Wayne Cervera, and where's Rachel Cameron? Yes, is she online? Earlier. Well, Wayne, why don't you come up and give us your thoughts on this particular. Wayne is a family physician from Psychiatric, Oklahoma, who's been involved in several of our projects, but has tried his best, I think, at least from my view, to integrate and try to do some of these activities. So, Wayne, your reaction to this particular effort?
Well, I didn't realize this was going to be a speaking engagement. I thought we were going to be doing more of a talk. Yeah. Well, my name's Wayne Cervera. I'm a family physician, and like a lot of people, I graduated woefully unprepared to deal with the population that I was going to get exposed to. And I've gone on into I've implemented MAT services in my office 20 years ago. I'm currently board certified in addiction medicine, and I'm a medical director for what I think is one of our, well, I'll say it's our state's best opioid treatment program in Tulsa, my point of view. And I practice in Psychiatry, which is 20 miles north of Tulsa, and I'm also a member of the Healthcare Workforce Training Commission, and so we're working on a lot of these access to care issues. And this is the first time I've gotten to a meeting where I heard that we were actually doing good in primary care. You know, I think we're really like 42nd nationally in primary care services, and so we really still have a long ways to go on that. And I'm also a small business owner. I'm an independent physician. I was really excited about learning about this model because I've gone so far in my practice as to give a local alcohol and drug counselor free space in my office. She'll just be there to talk to my patients and things. And so, is this really the best model for rural Oklahoma, do you think?
It can be. It can be. I think I'll flip the question around a little bit. But so, who is rural Oklahoma? And when you say that, I mean, what are we talking about? Are we talking about?
Well, I think the rural Oklahoma is served very well by OU and OSU. I know they have residency programs, and we have some good integrated groups. Integris has a big stake. Access Care Oklahoma, I see Ms. Denise back there, has some good stakes. But I think my office is actually about 150 yards from the Tulsa County line, and it gets really rural really fast when you get beyond the Tulsa County line, or even the Oklahoma County line where we are here. And so you recommended a team of 16 people, the CFOs and things like that. Can we really do that for a lot of our rural Oklahoma people with this model? Can we get there?
Yes, I think that, again, it's a great question. I think a lot of what I presented is obviously from a large health system perspective. A lot of the research has been done amongst large academic health systems. I'm actually applied for a grant to better appreciate what are the barriers for rural primary care practices towards implementing the collaborative care model. If you're referring to private practices, that's a whole nother barrier, right? Like, how do you implement the collaborative care model as a private practice? Because you need to find a psychiatrist. You need to find somebody who's going to serve as the behavioral health care manager. You need to develop your own homegrown model for how you can implement this in your practice. Are you even doing population screening? Do you need a full-time person in your practice, right? I mean, there's all sorts of really interesting questions about this. And so that does make the barriers really high, especially if there's all of these upfront costs, but it's not insurmountable. And what I will say is there are lots of psychiatrists who want to do this work. There are a lot of care managers and people in the local communities, social workers that would love to get involved in this kind of work. And so trying to understand from your community what resources are either local or what resources you might need to engage to get a remote version of this or a telehealth version of this, again, really depends on your practice and your care setting.
Right. Well, with my personal experience and also with some of the other physicians that I've interacted with who are rural providers, I really think we need a skinny version of this project where we could find a way to implement or place a master's level counselor in my office where they could generate, what's the average salary is probably $50,000. If there was a way that we can find, according to my sources, probably more. But if we could find a way just to make that where we could even just get a counselor without all of the other things that are required in this, I think that'd be a great program to work.
Co-located care is great. If you want to do something that's really highly coordinated like this, it is going to take a lot of upfront legwork. But you can share resources. So if your practice, I don't know how large your practice is like 2,000 patients, you probably don't need a full-time care manager because probably on average, I don't know how many patients, again, you're seeing per week, but this is where data is going to really help you. How many of the patients do you think out of your care population would rise to the occasion of being a good collaborative care patient? And once you have that rough number, do you have other friends in other rural communities that cumulatively could build up a nice caseload? Might you come together as a coalition, maybe look for some state funding or state support to, again, hire maybe a central collaborative care team that you all share, that gives you all access to a psychiatrist or maybe one or two psychiatrists and one or two mental health specialists that deliver all of their services remotely, but provide you with all of the information and all the resources to do things like drive the billing model that you can document locally on your EMR and drop the charges for those particular patients. That it's doable. It certainly is doable. It just takes a little bit of creative thinking and really looking for who are my partners, who could be my stakeholders in this. But you're right, collaborative care, not a one size fits all solution. You can go certainly on different areas of the integrated care chain and do just as well within your practice.
Right. And could you talk about scalability with the codes? And so if we have a counselor in the office and that person is billing based on minutes, how does that scale? Because I've heard, I watched some lectures and videos before I came today. I heard of panels for psychiatrists getting up into the 2,000 to 3,000s for people that are involved with the chronic care model. How does or collaborative care model? How does that scale at the practice level? Because I guess the revenue comes to the practice through the PCP provider, and then that revenue would have to be divided, I guess, to pay the counselor. And then how does the payment or how is the best deal with the psychiatrist?
Yeah, that's a great question. So the way that is organized at Emory is that the care managers are employees of the practice. So they are salaried employees of the primary care departments. Even though they're mental health specialists, they're actually in the primary care department. And the revenue, because the PCPs are the billing providers, goes back to the department of the primary care department and, gets distributed there. And also we carve out parts of the work RVUs that are generated also. So if you're in a work RVU system, you're getting you're getting credit for the work that you do there. In terms of the psychiatric consultant part, for our endeavor, I get 0.1, or I donate 0.1 FTE, so 10% of my time to every primary care practice. So if there's 100% of me, right, presumably 10 practices for one psychiatrist if you're doing it that way. Sure. Obviously, there's all sorts of other things in there because I'm an academic, so we won't bore you with the details. But and so think 10% of my salary, that's what they pay for per clinic, and that's as a contracted consultant. And so when we're doing our financial assessment or analysis within our programs, we take into account pretty much the cost of the care manager, which is the most expensive. Obviously, my time as a psychiatric consultant. Any incentivization bonuses the PCPs may receive based on the work RVUs that they might generate from this program. And then any IT or infrastructure costs that might need maintenance or sustainment. And again, the upfront costs typically wane over time once the infrastructure is established. And so that's kind of the core model of how it works at Emory. With respect to how the revenue funnels and goes, it's actually different across institutions and health systems, depending on who's driving the ship and how revenue streams are allocated. Very unfortunately for me, I would say, my revenue stream, again, all goes back to primary care. What I would love to do at some point is have my own integrated behavioral health revenue stream and to eventually carve myself out as my own service line. And the advantages of that are obviously that I have control over money and I have control over the rate with which I can expand my services. Because right now I'm lumped in with the entire primary care budget. And so I need to lobby to get funds from primary care in order to do things like ramp, scale, and expand my program. Your question about scalability, generally speaking, we talk about 100 patients, give or take, at any given point in time in active treatment in collaborative care. I will say most of my care managers' registries look more like 150 patients. Part of it is because of registry stewardship. Sometimes it's difficult to clean it up. Sometimes because patients, sometimes they kind of have this brief interaction with collaborative care, then they're lost to follow up for a couple of months, and they come back when there's a little bit of an urgent crisis. And so about 150 patients at any given point in time in an active registry is generally what we see with one care manager. And again, that's for practices in that 8,000 to 12,000 primary care patient total panel for primary care. So a good example of this too is, we are like the Starbucks of primary care in like one of our communities called Decatur. And, we've got like 12 primary care practices. Some of them are even like in the same building. Some of them are as small as 1,500 to 2,000 primary care patients. I would love to deploy collaborative care to those practices because when I do, data analysis, some of those practices have very psychiatric and psychologically minded PCPs, and they're doing a lot of mental health care. But I can't justify parking one care manager in those practices.
Right.
So even though those practices aren't rural, one thing I'm thinking about doing and that we're going to be working towards is to make all of the practices or the small practices in that location a cluster site, sharing one care manager, sharing one or two psychiatric providers. The care manager works mostly remotely and is on site maybe one day a week at each practice to help curate a patient population. But again, the fact that you have a registry, and every patient that's on your caseload makes this so much easier to manage patients, even if they're in different geographic locations. And so I think that's where the true power of the scalability of collaborative care is. Now, how scalable it is also going to be dependent upon that back-end resources that you may or may not have. So again, if you have a bridge to nowhere, you're going to get stuck with a lot of people who are going to be stuck in collaborative care. And that is a problem. And sometimes you have to tell the patients that I think we've gotten you good enough. Here are the additional resources that I'm going to recommend. I really would like you to get back involved. But right now, I think we're going to take a pause on treatment, even though you're not perfect or you're not 100% better. And that is, again, you have to wear a very different hat in this role. It's a population-based approach, greatest good for greatest many, and picking reasonable treatment goals and targets for our patients is actually a pretty important part of that sustainability and scalability component.
A minute ago, you kind of, I don't want, if anybody else has questions, I'm sorry. Just a minute ago, you talked about, you touched on the compliance issues. Could you talk about what are the requirements of the registry? And you also mentioned on one of your slides about the weekly meetings that were required and kind of what are the components of that?
Yeah, so CMS doesn't provide very much direction about what that looks like or what that is. So a registry, whatever you want. As I mentioned, it could be as simple as a really nice Excel spreadsheet that somebody manages. Although Excel spreadsheets, once they get sufficiently large data sets, tend not to be so good over time. They can be, again, some sort of way of culminating medical record information from, extracting medical record information from your EHR using things like Power BI, which is a Microsoft Office product, which usually can extract and kind of transform data really easily. The registry can be many different things, and it doesn't need to be one thing. So our registry actually has multiple components. So I have, for our health system, I have an EMR-based way to aggregate all the patients on a caseload. I then have a separate dashboard that extracts much higher level data that the care managers don't really need access to on a daily or a weekly basis, but we review as a team on a monthly or quarterly basis. And so really, it just means having an ecosystem to look at data with some sort of regular cadence. But it is a requirement that you review at least the population quality data in terms of like who's getting better, who's not getting better, and what the trajectory of scores are. That's generally the things that CMS is kind of looking for. And then your other question, I'm sorry, was about
what do the weekly meetings look like?
Oh, so the weekly meetings look like this. So usually I earmark an hour and a half for a case consultation visit, although they typically only go for about an hour. And we set an agenda. So the agenda for all the care clinics are, you bring me cases that you would like to talk about. And when I say you, it's the care manager. You can use them as often open office hours for PCPs to come join. But in our practice, the PCPs are so busy, they're not coming to office hours. So it's really care manager and they bring me cases and we talk about them for about a half hour or 45 minutes. We get through as many cases as we can. And again, it's generally this patient is not getting better. This patient is having a medication side effect. Can you help figure out what to do? This patient didn't want meds initially and now is ready for meds. That's a big one that often comes on. Again, primary care population. I don't want a psych med. We're ready for psych meds. I need help with diagnostic clarity. What would you recommend I do to help understand what's going on diagnostically with this patient? We'll talk about that patient for 10 to 15 minutes. I usually don't like it to run over at 15 minutes unless it's a really complex patient. And then I'll chart a quick case consult document or note in the chart. I'm usually doing concurrent documentation. And if there's anything for the primary care provider to action upon, I route it to the PCP and say, hey, we talked about this case. Good news is XYZ is going on. Bad news is I need you to tune up the antidepressant. And PCP says, great, I'll have my nurse call in the script or whatever, and then we go on our way. Then we reserve the latter half of the time for the registry review. Okay, now let's look at the registry. I'm gonna reorganize the registry. Who's got the highest PHQ-9 score? Have we talked about this patient? Okay, Mrs. Smith we talked about last week. Mr. Jones we talked about 2 weeks ago. What happened to Lavana? Where is she at? She's screaming high PHQ-9. She kind of fell off the face of the planet. Oh, she got admitted. She's got renal failure. Okay, let's talk about her next week. So we kind of march through the patient population and talk about people who we haven't talked about. Oh, and then I'm going to re-stratify it based on low PHQ-9. So Mr. Johnson's been doing really well. Like the last 3 PHQ-9s were less than 10. Seems like he's getting back to work. What's your plan moving forward, care manager? Oh, you know what? I think this is a good time maybe to start thinking about discharge or graduating the patient, right? So you're using that time to help the care manager really work with the patient population, and you're giving them space in their day to think about all of their patients. Who would love that, right? Who would love time in their day to think about their whole population and really look like, how are my patients doing, right? How good am I at managing diabetes, right? We rarely have that opportunity. This demands it of us on a weekly basis. So that's what we use our case consult time.